Welcome to Radiology, a podcast by University Medical Imaging Toronto, where we discuss the most interesting topics through the lens of Canada's largest medical imaging department. I'm your host, Satish Krishna. Don't we all love an amazing reunion story? You know the ones I'm talking about, like in movies, in which there are two siblings, long-lost brothers who get parted in life, and then finally, after years of flourishing in different places, they reunite. This is one such story. It was the year 1895 when Willem Conrad Röntgen discovered the X-rays, and it was late in 1895. But early 1896, within a few months, Emil Grube had used the same X-rays to treat cancers. And one could say that that was the birth of radiation oncology. So they were almost like twins, kind of born almost at the same time, just a few months separate from each other. And they grew up together. The diagnostic radiology and therapeutic radiology were all done by radiologists till the end of the Second World War, and there were hardly any radiation therapists. It was only in the 1950s when there were proper training programs for radiation oncology. It was only in 1975 in which the ABR had separate diagnostic and therapeutic radiology branches. And it was in 1997 when the American College of Radiology and American Society of Radiation Oncology were separated. It's been about 30 years since, and both of these siblings have flourished. But now, it's time for a reunion. This is Radiologist. I am a radiologist, Satish Krishna, and we have with us a radiation oncologist. Not just any radiation oncologist. She is an internationally renowned radiation oncologist, Dr. Mary Gospodarowicz. She needs no introduction because everybody knows her. She was one of the most successful chairs of the radiation oncology program, and she's a recipient of the Order of Canada, which is one of the highest civilian awards awarded in Canada. Mary, it's such a pleasure to have you here.
Thank you. Thank you for inviting me.
So one of the first things I want to ask is that we have practiced now what is considered two different specialties. How did you get into radiation oncology, and weren't you ever allured by radiology when you started? Was radiation oncology separated like in the 70s when you were training already? Was it separated enough from radiology?
Yes, in fact, I was training in internal medicine. Mm-hmm. And when I was training in internal medicine, I knew I wanted to subspecialize, but I didn't know what I wanted to do. And I was approached by people from Princess Margaret saying that they wanted to have trainees in radiation oncology with internal medicine background because of growing complexity of cancer and cancer treatment. So I thought I'll take a year out of my internal medicine and do a year of radiation oncology, see what it's all about, because as you know, as a medical student, you have no idea what radiotherapy is. And I must admit, I did the first year at Princess Margaret, which was half medical oncology, half radiation oncology. And actually, the head of medical oncology then told me, "You're an internist, why don't you do medical oncology? Because radiotherapy will stop being used for cancer in the next decade because we'll have better drugs." So he wanted me to switch the programs. But I stayed in radiation oncology, and because of medical oncology and my internal medicine background, did actually both radiotherapy and chemotherapy for a period of time. So even at that time, we were separate specialties.
Okay.
But there was no professional association of radiation oncologists. We were actually a member of CAR, the Canadian Association of Radiologists. About a decade later, we wanted to establish a Canadian Association of Radiation Oncologists, but everybody was very worried. We didn't want to upset our brothers in radiology. We thought that they would be terribly upset. So we went to the executive committee of CAR and they said, "What took you so long? We know, we know you're different. We know you have different specialty, you have different exams, different practices. So the divorce was finalized actually only in 1980s when we started having separate professional associations, as you say.
Yeah, well, I don't really think of it as divorce. As I think of it as you're leaving, setting out to create your own adventure, and bring a wealth of new ways of doing things. But that said, this is kind of interesting to me because you were trained kind of both in chemotherapy and the radiotherapy things. And now medical oncology and radiation oncology are separate specialties. But more recently, when I look at literature, that seems to be a significant overlap in which there is a lot of trials coming and saying that during radiotherapy, if you give 5-fluorouracil or you give chemotherapy drugs, the efficacy is kind of much more.
So, in Europe, there is a specialty that's called clinical oncology. And the clinical oncologists are trained in both. So, for example, in the United Kingdom, there are medical oncologists and there are clinical oncologists. There are no pure radiation oncologists. So every radiation oncologist is a clinical oncologist, and they can do both. Now, your pattern of practice may be that you do more radiotherapy than chemotherapy, but you're trained in both specialties.
That's very interesting. But how did medical imaging fit in the picture? Because from what you say, you were trained in clinical oncology, but many of the advances of medical imaging came much later, in which we did have CT and MR, but it was quite rudimentary back in the 70s and 80s. And significant improvements came in the 90s and 2000s.
So it's very interesting what happened. So the radiation planning was always based on imaging, but we would do an X-ray of the patient, determine what area of the body we wanted to treat, and then in your brain, you sort of transferred the knowledge of where the disease is onto the simulator, which was doing plain X-rays, and you transferred using the marks where you wanted to treat. But what happened in 1990s was the integration of CT imaging into the radiotherapy process by using CT simulators. And then in late 1990s, really 2000, 2001, we started having CT imaging built in onto linear accelerator. And then suddenly, within the sort of space on 10 years, the practice of radiation oncology got totally transformed. It was totally image-based. And we started getting much closer back to imaging.
Back to your roots.
Now, the difference between the medical oncologists and radiation oncologists, we always were trained to look at images. So we always read the reports that you give us, but we always looked at images.
Okay.
So, I grew up looking at images, even though I was not trained in radiology. And that persists to today. But today, because of integration of imaging into radiotherapy process, we actually give our residents a part of education in interpreting imaging because it's so necessary.
Oh, that's amazing. So you're saying that image interpretation is actually part of training for radiation oncologists?
Yes, obviously not to the same extent as diagnostic radiology training. And that's why sometimes for critical treatment planning in difficult situations in abdominal imaging, brain, or head and neck, we actually sit down together with diagnostic radiologists to interpret planning imaging to outline the area that we're interested and that we should treat. Because we always say that you report on imaging, but we actually make big treatment decision based on images.
And that's amazing because quite a lot of times we have staff come to us and ask questions as to where we think the extent of the disease is. And we feel really happy because we're able to share what we do and to improve patients' outcomes, because a lot of times we are behind the scenes, whereas you are right in front and center. One quick question I wanted to ask is, if radiation oncologists all do get medical imaging, medical interpretation training, do you think the vice versa should always also be true, in which radiologists should also get some training, at least for a month, on what's being done in radiotherapy? it's not really going to help us treat patients, but it appreciates the nuance of what you do and what you need for your treatment planning so that we can tailor our reports or tailor our discussions accordingly. I think currently that's a deficiency of the system. Do you think that something like that would be beneficial to the radiology community?
I think so. To a certain extent, you do get exposed to that through our interaction in planning rooms or tumor boards, where we interact and we ask each other's questions. And I think the collaboration at the tumor boards, which official name is Multidisciplinary Cancer Conferences. Is that's when the radiologists, I think, have a first-hand exposure to how important their reports are.
Absolutely.
In decision-making, and how important different detail is. And it's that importance, I think, is growing as the tools that we have for treatment of cancer are changing. So, we have treatments that can produce different effects that on imaging look like progression of tumor, but it's pseudo-progression. So we're all learning together
Absolutely.
on how our treatments impact on the images that we see. And you need to learn from our outcomes and results of how to interpret the images, right? Because how do you know whether it's real progression or pseudo-progression? Because of the outcomes. So I think that there is more and more integration of different disciplines and specialties that I think is around the problem or around the patient. Mm-hmm. So if you put the patient in the center mm-hmm. and think what is the important decision for the patient, then I think it sort of crystallizes what's needed from each discipline.
Absolutely. And I think that as over time, you've gotten better and better at treating, because a lot of diseases which were considered palliative or not treatable, you're not able to offer almost complete cure now. So when you're getting better and better, that forces us to be more and more precise, because tiny details now become very significant. Early side effects, we need to pick it up and point out to you. And as you point out, a lot of this complication in which post-radiotherapy treated, like some of the cancers, like I would assume HCCs and RCCs used to be considered radio-resistant. And now SBRT is commonly used for these cancers these days as well. And the post-treatment imaging appearance is quite different than any other modality. So that actually forces us to evolve as well as you continue to evolve. But speaking of evolution, as I was pointing out, ABR was initially diagnostic and therapeutic was considered radiation oncology. But now the diagnostic side, we now have an interventional radiology which caters to therapeutic aspect of it. And we could argue that, well, that's radiation, this is like non-radiation, but interventional radiologists now use yttrium embolization. And more recently, we now have theranostics, which is injecting radionucleotides for directly targeting cancer cells and treating it. And this essentially blurs the line between what we think radiology is and where one ends and where one begins. So it kind of seems like we set out on different journeys, but now the lines between two specialties in some of the places in between is blurring significantly. So how do we go ahead from here? What happens next?
You're right. It's fascinating, right? It's very interesting. But it's happening not only in radiation oncology and radiology, it's happening with surgery in radiology. You said interventional.
Yep.
It's happening in surgery and, for example, respirology. Gastroenterologists do a lot of procedures that sort of border on surgery. And so I think that it would be nice to imagine the world where we are more concerned with what do we need to do to help the patient rather than which department do we belong to.
Okay.
If we didn't have any barriers, any silos, any borders, this collaboration would be much easier.
Absolutely.
We still need, specialty defined competence. Mm-hmm. But we're moving into an era of competence-based education and training. And maybe it's time to rethink whether this competence is necessarily needs to remain within the walls of departments, or should it be based around addressing a problem? I often think it would be fascinating to see the world where we could eliminate the specialty silos and just redefine how we address the problems that patients face, and who and what skills we bring to the table to address the challenges that modern medicine poses. And there are many, because we're getting new tools, whether new imaging tools, molecular imaging. There are new pathology tools with molecular probes. Now we're doing a lot of ctDNA and liquid biopsies. What does it mean?
Yep.
How do we interpret that? And I think that I sort of see that it's the time to rethink the specialties.
Well, that literally blows my mind, because fundamentally, when people talk about breaking silos, the general rhetoric is that, you know what, we need to collaborate more. Let's get together. Let's have tumor board meetings. Let's get to know what each other do. But what you're proposing is not just collaboration or teamwork, but elimination of borders and creation of new specialties which are bordering on both. So in a way to explain this to my radiology colleagues, and this is something all radiologists understand, when we take CTs, we take let's say 5 millimeter sections. The second section is not separate. We always have a slice overlap, because otherwise we think that if there are 2 slices here, you might have missing data between the slices, which might be problematic. So where there's always a slice overlap. I think that what Mary is proposing is to have people with overlapping skill sets, and then you bring in the people necessary for treating those patients.
You probably already have it. You have neuroradiologists who are a little bit of neurologists and a little bit of radiologists. You have cardiac radiologists who are a bit of cardiologists, right?
Absolutely.
So it's already happening. In radiation oncology, we already have people who subspecialize in brachytherapy, which is really surgical insertion of radioactive sources into the tumor, right? So they sort of border on radiation oncologist, small procedure surgeon.
Okay.
Then we have radiation oncologists who do a lot of palliative radiotherapy, but they also have a lot of competencies in palliative care. So they're sort of bordering of palliative care physician, radiation oncologist. We have radiation oncologists who do more of chemotherapy as part of combined modality treatment. So their sort of function as clinical oncologists doing both chemotherapy and radiotherapy. That does not change the requirement for medical oncologists, for surgeons, for others. And I think that we will have radiation oncologists who will have a little more competence in imaging, maybe to work in theranostics and in the areas where imaging is crucially important.
Absolutely. So I think especially with AI coming in, which is going to radically revolutionize imaging, I'm assuming that AI is going to have a huge role in radiation oncology as well. And in that setting, you probably need people who understand AI, understand images, and how it's applicable.
It already does, actually. You know, we work very closely with medical physicists. So medical physicists are actually original AI experts in our world. And we, at the present time, we have scripted planning for postoperative radiotherapy for breast cancer, where normally a dosimetrist or planner would spend a couple of hours developing a radiation treatment plan for postoperative breast radiation. We now use scripted computer program that does the same plan in 4 minutes.
Oh, wow. Okay.
And prostate cancer, computerized treatment planning would take a dosimetrist a couple of hours or sometimes 4 hours. The computer does it in several minutes. And we have validated and published that the results of this type of use of AI and computerization has been validated as good as we planned. So therefore, you can overcome the shortage of human resources by using AI. You do that too, obviously.
Absolutely. Yeah.
I remember when the first CTs were implemented and the radiologist had to flip sort of 30 sheets of film and look at 300 images and took half an hour. And now using modern computer PAC systems, you can report the same study in minutes, right?
Surprisingly, when I was trained in radiology, during my residency, we still had that. We still reported on films. We had the whole thing kind of rolling, and after first 2 years, then we moved here. So the entire history of radiology was condensed during my radiology training. It was so fun to see the evolution and how things can change very quickly. One of the things is that, like you point out, like when eliminating these silos, currently there are a lot of people who are cross-appointed, cross-trained. Do you think that leaders should be bigger proponents of this? And where does this start? Does it start after med school? You have like residency programs in between, new residency programs created? Or do you think that it's still going to be that the residency programs are going to remain as is and then the fellowships are going to be like cross-trained? Because currently there is a barrier because they've got to do 2 separate residencies, and sometimes it gets longer in terms of number of years spent to get that core competency. Could it be done faster or in a better way? And what are the roles of leaders in that? Because you've been a leader and pioneer and all your life.
So you mentioned before that we have more and more tools and that we can do more and more for cancer, but that's probably true in all the disciplines. We have much better drugs, technologies, ability to treat people. So medicine is getting more and more complicated and therefore more and more expensive. And we're all complaining of not enough resources, whether it's human resources, technologies, but yet we won't change the way we do things. So, it was Einstein who said, like doing the same thing over and over again and expecting different results, a form of insanity. But that's exactly what we're doing. We have all these technologies, we have all these ideas, and yet we're stuck in the sort of 19th or early 20th century doing the business, right? And I think you're quite right that I think the leaders should start reimagining how to do things differently to overcome the complexity of the health systems and also improve the access and equity and basically not work harder, but work much smarter, right?
So one thing which really strikes me as very interesting in this entire conversation is that when I'm speaking to you, I really see the passion come out, the way you want to make the world a better place, the way you want to close gaps in care, the way you want to increase access across. And the reason I'm pointing this out is because many people who may have been in your seat would have said, I received the Order of Canada. And in fact, you were actually the president of UICC, and UICC is a prestigious organization. You were the president. And if I'm not mistaken, you were the first women president between 2012 and 2014 of UICC.
As physicians, we are brought up to help an individual patient.
Absolutely. Yep.
And so you practice medicine, you're a radiologist, I'm a radiation oncologist, we help people. After a while, you sort of try to figure out how can I help more than one patient. You're doing these podcasts by educating people, help a lot of people. They, showcase the importance of imaging to many, many people around the world. So you figured out how to help more people than the patient that you deal with. And I think if each of us spend 10% of their time, 15% of the time, 5% of the time of trying to figure out how to make the system works better for patients, then hopefully we would be less upset that the healthcare system is not working very well.
Wow. That's because normally it's easy for anybody to complain and people love complaining. But if you do spend some amount of time trying to improve the system, and I guess I get your point as well, we need to be a little bit greedy. It's not enough just to help one patient or one resident. What if we can help multiple people at the same time? What if we can do something bigger? And as you point out, it takes the same time to think big as to think small. So why don't we have a bigger impact?
And we all work in a very complex system, right? Healthcare system is hugely complex. Mm-hmm. And we no longer practice, like the doctor 100 years ago had a little black bag, went to the patient and was like a solo practitioner and didn't need the system behind them. But today, we need the system behind us. We are very interdependent. Mm-hmm. A solo physician cannot do very much on his or her own. But you talk before about the fact that we don't get cross-training about specialties, but mm-hmm. we also don't get training how the health system works. Absolutely. So you work in the system that you don't understand, and it's very difficult to fix it if you don't understand it. So actually, the last thing that I was doing for UICC together with Meredith Giuliani, one of my colleagues, as a chief editor, we've actually wrote a book on cancer and health system for health professionals, basically talking about what is the health system, how does it operate, what is the political economy of cancer, mm-hmm. how are decisions made, what are the bigger issues other than the issues that you face in your own practice. Because I think if you understand it, then you can do something about it.
This reminds me of something which my mentor, Dr. Anya Keeler, used to always say. She always said that, it's similar to the Hamilton musical, you should always have a seat at the table. You should always be in the room that it happens. We often think that, my job is to look at the patient. That's what I'm trained for. And you're absolutely right. We don't get trained in leadership or administration or advocacy. We just get trained in patient care. But then I think that we do need to start thinking about all of that. Because if we just leave all the decision-making to managers who don't quite understand the complexity of patient care, then there can be a significant disconnect. And the exact same problem of silos start happening, in which we work in our silos, they work in theirs. So it's amazing that you have been front and center of all these organizations and, be like that captain of the ship who steered the entire ship in the right direction, onward and beyond. That's just incredible to have great leaders like you and inspiring generations of people after you as well.
So seat at the table is important, but you need more. So there is a business professor at Harvard, Rosabeth Moss-Kanter, and she talks about steps to success. So how you can stimulate change. So she says, first of all, you have to show up. So if you're on some committee, show up. Yeah. But that's not enough. Mm-hmm. You then need to speak up. Mm. Because if you just sit there, not enough. Yep. So you need to show up, speak up. Then you need to team up. Mm-hmm. Okay. Then you need to lift up. So elevate the discussion to something more important. Then you need to actually lift others up. So encourage other people to do things. So I think that, yes, participation is important, but also progression of the engagement.
That's incredible advice. For anybody else in medicine or people thinking of medicine or any medical students who are thinking of how to structure their career to have the maximum impact, what advice you would give them?
Engage. I think that, first of all, I think we all go into medicine and healthcare to help people. So everybody is very motivated. So what do you need then is you need a skill set. And because of the complexity of healthcare and medicine today, you also need training not only in your specialty, but also in leadership. And we've actually started doing it at Princess Margaret. We have a young leaders program where we actually invite new staff members, new managers together with different disciplines to come and have a little bit of formal training in leadership.
That's amazing. So for all you leaders out there, all people who want to be great leaders of the future, University of Toronto, University of Medical Imaging Toronto is one of the best places for you because the path is laid out. One thing I wanted to say before we finish is that medicine started off, as Mary pointed out, as a single provider institution in which one provider was providing everything. Over time, what's happened is that there have been lots of specializations and subspecializations, and we have started working separately in silos. Radiology and radiation oncology, which were siblings, have kind of moved away. But now later we realize that the lines are blurring. The long-lost siblings are coming together, not just in our fields, but in pretty much every other field. Think of it as a mesh, as a beautiful spider web. Think of it as all kids coming together in the playground. And as Mary pointed out, show up, team up, speak up, hold each other's hands, and elevate everybody. And within this circle, at the center of it, there is your patient. And this team up, like the Avengers or like any other awesome team ups in history, that's what needed to make patient care much better in the future. Ladies and gentlemen, that was Dr. Mary Gospodarowicz, and I'm your host, Satish Krishna. See you in the next one. You were listening to Radiologists, a podcast by University Medical Imaging Toronto, the largest medical imaging group in Canada. Produced by Ina Levchuk. Learn more about us at universitymedicalimagingtoronto.ca and follow us on social media at Imaging Toronto.